Okay, in an effort to try and keep us better on schedule than we currently are, I wanted to do a recording on exercise physiology and hope that you'll be able to watch this outside of class, bring any questions you have to class, and then hopefully on Wednesday I'll be on schedule, be able to post our third exam. I think when we look at exercise physiology, it brings together all of the attributes or characteristics that we've talked about so far in both lung function and cardiac function, in that when we exercise, we're going to stress all of our systems. And in fact, training is going to increase the productivity of each one of those systems to an extent, and we'll talk about some of the limitations today. Failure to stress ourselves adequately in an exercise physiology standpoint obviously leads to some side effects that our population currently suffers from. One of those is adult and childhood obesity, type 2 diabetes, etc. So, everybody get your exercise. When we talk about exercise, this can be described from a physics standpoint in moving a mass through a distance. Now certainly in order to do that it takes energy, and from an exercise standpoint that also includes burning calories. Now it just so happens that burning those calories aerobically requires consumption of oxygen, and that's what we're going to be looking at when we do exercise testing. If we do this aerobically, we're going to generate more ATP than doing it anaerobically, although anaerobic metabolism generates a lot of ATP fast, or I should say it generates ATP fast, but a limited amount, versus doing it aerobically generates a lot of ATP, which is the high energy phosphate that we actually utilize to do work. So we have to measure oxygen consumption. We've already talked about VO2 as a function of metabolic rate. We talked about that with work of breathing. We talked about that with fever. But we're also going to be using VO2 to identify the level of exercise that somebody is doing. The harder we work, the more calories we burn and the more oxygen it takes. So VO2 increases linearly with exercise. The harder we work, the more oxygen we consume. VO2 max is a measurement that we'll do primarily in athletes, and we'll put people either on a treadmill or an exercise bike or some other ergometer. Ergo is Latin for work, so a work measuring device, and we'll be able to push people to their limit of performance if we do a VO2 max measurement. Certainly we don't do this in patients with heart disease and lung disease. We do modified tests called symptom limited tests or submaximal tests. Normally, and this goes back to the Fick equation, we would measure VO2 by having an arterial blood sample, a mixed venous blood sample, which now that we've done the cardiac chapter, we know is typically going to come from the pulmonary artery because we need to thoroughly mix all of the blood. We have to have a measurement of cardiac output, and then our little conversion of 10 deciliters per liter. This gives us a value for oxygen consumption. And this is still something that is physiologically done, although it takes invasive monitoring, like getting a sample of blood from the pulmonary artery. When we look at exercise and the extraction of oxygen, this AVO2 content difference, and you all know how to calculate content, is typically referred to as the AV oxygen difference. The other thing that physiologists will look at, and in the critical care unit we may also look at, is an oxygen extraction ratio that deals with how much oxygen is taken out of the blood relative to what has been delivered. When we do exercise, we talked about the fact that catecholamines such as epinephrine are released. We have to increase cardiac output, and specifically we want that cardiac output to primarily be directed at the more active tissues. So when we're looking at the legs riding a bike, the diaphragm and other accessory muscles of breathing, because they become more activated with exercise. And certainly the heart, which is pumping more blood, it's going to consume more oxygen. So when we start to increase cardiac output, Initially, we're going to do that with an increase in stroke volume. We're going to have an increased ejection fraction, and that may go up into 70 or possibly in well-trained people 75%, so that there's only 25% of end diastolic volume remaining at the end of a stroke. But that is really limited. It'll max out stroke volume fairly early in exercise. So once we get to about half of our max VO2, we don't really have any further increases in stroke volume. The rest of our increase in cardiac output then has to happen from other factors, notably increases in heart rate. As we exercise, we're going to use that skeletal muscle pump more. That's going to be squeezing blood that we normally would store in their venous circulation. It's going to squeeze it back to the right heart. When we breathe deeply, we're also going to use that respiratory muscle pump, and as we make a vacuum to breathe in, that also sucks blood back up to our right heart. That's going to increase our preload, and through the Frank-Starling law of the heart, we're going to be able to increase the amount of tension the heart's able to generate and increase stroke volume until it plateaus. As far as heart rate increase goes, typically we're going to look at a way to estimate maximum heart rate, and that's based on 220 minus age. I know there are equations for males versus females, but this is certainly close enough for government work and for this class. I'm nearly 60 years old, so my maximum heart rate is only 160 compared to somebody who's younger in the class. Jeepers, they can have a maximum heart rate of about 200. Therefore, a younger person is able to generate a higher cardiac output than an elderly guy like me. Therefore, they can deliver more oxygen to the tissues. As I become limited in my ability to exercise due to a lack of cardiac output, I also have some changes in my lung. In fact, vital capacity decreases with age. And in a normal person past age 40, if I remember correctly, we lose about 30 milliliters per year of forced vital capacity. So the heart isn't the only organ that really changes as we age in terms of exercise capacity. We have some loss of lung function as well. Since we're exercising, these tissues are using more oxygen. They can extract a greater amount of oxygen, so the AVO2 difference dramatically increases, even though cardiac output goes up 4 to 5 times resting. Since we're extracting more oxygen from the blood, and if you think about the equation, we're probably not increasing the arterial content dramatically, we're reducing the mixed venous oxygen. We have less left over if we extract more. So I want you to think about a normal resting AVO2 difference. And hopefully you'll come up with some sort of a close value based on the calculations of arterial and mixed venous content that we've done in the past. This is taken from a research study where they were looking at extraction of oxygen from the blood in a bicycle exercise ergometer test. So on the y-axis we've got oxygen content, and as we know that's milliliters of oxygen per 100 milliliters or per deciliter of blood. And we're looking at a couple of blue graphs here. One is the mixed venous oxygen and the other is femoral vein content. So notice that we don't really have any change in the red line here that's particularly dramatic. We start with a resting oxygen content of around 20 cc's of oxygen per deciliter of blood. It doesn't dramatically drop with exercise. It goes down just a little bit, and we'll talk about why. And this is probably in an athlete who really is very well trained. We notice that mixed venous oxygen drops, and that's because we're increasing that AVO2 difference. In other words, we started with an arterial content of 20 and a mixed venous of 15, so if you did your math, you have an AVO2 difference of 5 at rest. With this high level of exercise, the harder we work, the more oxygen we extract, and the AVO2 difference increases dramatically. So if this value is 5, this value for mixed venous oxygen is 3, We have an AVO2 difference of 17 milliliters of oxygen per 100 milliliters of blood in this research study. Notice if we're measuring blood in the femoral vein, in cycling the legs are doing the vast majority of the work and consuming the vast majority of oxygen. So if we only looked at femoral vein leftovers, we would not be really reflecting what's going on in the whole body. We would be reflecting what's going on in those primarily working tissues. So it's important that you know where your blood samples come from. So, changes in AVO2 difference with exercise. Since the legs in a bicycle ergometer test are doing the work, we really want that blood and oxygen delivered to primarily the legs. So we need to dilate those arterioles to the exercising muscle. And I want to go back to those factors we talked about with the Bohr equation, with the Bohr effect, excuse me. With the Bohr effect, we said that if you have hypoxia, acidosis, or high CO2, we're going to have hemoglobin releasing oxygen to go to the tissues, because we need to get oxygen to go into the tissues for metabolism. Well, you want to connect this with blood flow. If these tissues are becoming warm due to exercise, they're using more oxygen, they're producing more CO2. That's also some of the factors that probably cause vasodilation, probably through production of nitric oxide, which we talked about as a vasodilator, that's going to dilate those arterioles leading to the exercising muscle. Because we're dilating those arterioles, it needs to be balanced by constriction of arterioles to other beds. For instance, the gut. Your mother told you not to swim until 30 minutes after you had lunch. So maybe your mother was an exercise physiologist and realized that since you're diverting blood flow to exercising muscle, it's not going to go to your gut and help you digest the cheeseburgers and french fries that you had for lunch. Maybe mom was just really just a mom, but who knows. The larger muscle mass you use with exercise, the more capillary bed will become dilated. So if you're a cross-country skier who's using arms, legs, torso, if you're a swimmer using arms, legs, you're using a large muscle mass, you're dilating a lot of vascular beds, even though others are constricting, there's potential for your overall SVR to decrease because you're dilating so many tissue beds. But again, that has to be balanced by an increase in cardiac output in order for us to have adequate blood pressure. And in fact, we do have increases, particularly in systolic blood pressure with exercise. So we said when we exercise, these joints are going to start to be moved. We've got those joint receptors, Golgi tendon organs that are going to send signals back to the brain where everything gets coordinated. Once we know that we're moving, it's going to encourage us to do deeper breathing because we need to get more oxygen in the system. We need to ventilate off more CO2. With that deeper breathing, we get an increase in venous return through the ventilatory or respiratory pump as well as the skeletal muscle pump. And that venous return is going to help us to increase cardiac output. We also have the release of catecholamines that is potentially going to put a little squeeze on our venous circulation and tighten it up a little bit and encourage some more venous return. And that sympathetic output is also going to increase heart rate through stimulation of those beta-1 receptors that we talked about. It's also going to increase contractility. And since we have more venous return coming back to the heart and more catecholamine release, we're going to have an increase in stroke volume. Both an increase in heart rate and stroke volume give us a greater cardiac output. We said we're going to vasodilate arterioles that lead to exercising muscles. So hopefully we're going to send that cardiac output to exercising tissue and vasoconstrict to viscera, the organs that we're dealing with, for instance, the bowel, the gut. Since we're vasodilating hopefully a large muscle mass with large body aerobic exercise, we're going to decrease SVR, and that's a good thing because if SVR, if resistance stayed high, it would be very difficult for this heart to generate that increased cardiac output because it would have to pump against a greater afterload. So that also helps us increase cardiac output, and we want to get this oxygen delivery to the exercising skeletal muscles as well as the heart, the diaphragm, other muscles of breathing. So that VO2 measurement that we talked about, if I'm doing this an exercise test on a normal subject, an athlete, I'm not going to really directly measure cardiac output. I'm probably not going to put an arterial catheter in somebody, nor am I going to draw arterial blood gases, and I'm certainly not going to put in a Swan-Ganz catheter. We're going to measure exhaled gases. And the reason for that is there's a connection between the exercising tissue, the blood, which is bringing blood back to the heart from exercising tissue. That blood will perfuse the lung. The lung is going to exchange gases, and we'll measure exhaled gases to tell us what's going on in the tissues. And we can actually do this. Boise State has got a portable metabolic measurement device, metabolic cart, if you will, or indirect calorimeter. Indirectly, we measure the calories that are burned. And this is a really cool device. It can be used for exercise. It can also be used, for instance, in the individual on the bottom right who looks like a firefighter to try to identify what his workload is when he's aggressively doing whatever his job is. So in order to measure oxygen consumption, we're going to measure inspired oxygen concentration, expired oxygen concentration, which will be expressing as a fraction, as we've done before. FiO2, we're breathing a 21% oxygen mixture, so our FiO2 is 0.21. FeO2 is probably around 0.16 at rest. That will decrease with exercise as we extract more oxygen. So what we're saying is the oxygen that we consume is the difference between the amount of oxygen we breathe in, which is minute ventilation times FiO2, and the amount of oxygen we exhale, which is the minute ventilation minus the FeO2. We're assuming that volume inspired is the same as volume expired in this equation. So if I have somebody who's got a normal minute ventilation of somewhere around 5 liters per minute, breathing 21% oxygen, an FiO2 of 0.21, and an FeO2 of 0.16, we get a VO2 of around 250 milliliters per minute at rest. And this is the normal VO2 measurement or value that we've talked about in class. If I look at measurement of arterial blood gases, if I have a Swan-Ganz catheter in our arterial line, I have a cardiac output of 5 liters a minute. If I have a arterial content of 20 cc's per deciliter and a mixed venous of 15 cc's per deciliter, which is what we had at rest on that graph I showed you with exercise with a bicycle ergometer, times 10 deciliters per liter, our little correction factor, lo and behold, we get the same value for VO2 if we do the measurements of blood or we do the measurements of exhaled gases. This is really only true, though, when we're in a steady state. In other words, if I can exercise, or in this case be completely at rest for a period of time and make our measurements during that resting period in a steady state, then those two values would be absolutely the same. If we're changing our workload every minute, that may not be the case. In fact, is not the case. But we have a volume of oxygen that is consumed that we can quantitate. We also know that we're going to take exercise measurements and compare oxygen consumption for different body sizes. If I take the larger students in class, like Eric, who's a muscular hockey player, he's much bigger than some of the petite ladies that we have in class. Their resting oxygen consumptions then would be very different because primarily of a difference in muscle mass. So if I correct that oxygen consumption for body mass or body size, I'm probably going to get a more comparable value. And in fact, when we do that, we're going to divide oxygen consumption by body weight in kilos, and we get a value that we express as milliliters per kilo per minute. The other way that we'll use this value is that if resting oxygen consumption is 3.5 mils per kilo per minute, we're going to call that one metabolic equivalent. Now, for those of you who wind up going into cardiac rehab, and I know that we've got some exercise science students that are probably going to do internships in pulmonary rehab or cardiac rehab. Particularly in the setting of cardiac rehab, METs are the way that we will explain to patients how hard they're working and what their limitations of exercise and work should be. For instance, we could tell patients that light housework, dusting and maybe sweeping, might be 2 METs. Vacuuming might be 2.5 METs. Sex has been described in METs. So patients know when they go home after a heart attack, what can I do? Can I go out and rake leaves? Can I shovel snow? Can I have sex with my spouse? Seriously, this is something that has to be discussed in a cardiac setting. So METs are a way that we'll evaluate that. We know that we increase CO2 production with exercise. We've talked about that before. Now, since there's essentially, we're saying no oxygen or no carbon dioxide in our inspired gas, we don't need to worry about inspired CO2. So to measure VCO2, we're going to look at the percentage of CO2 or the fraction of CO2 in our expired gas. That CO2 is coming as a byproduct of metabolism, a waste product of our body's metabolism. So we look at a minute ventilation, normally 5 or 6 liters a minute. If we have a fractional expired CO2 of 0.033, we multiply those together, we're going to be able to come up with a value for VCO2. And we talked about 200 milliliters per minute as being a pretty normal value for resting VCO2. We used that when we were talking about all of our CO2 carrying in that chapter, for instance. So we said VCO2 is that byproduct of metabolism. Well, we're also going to be looking at it in terms of efficiency of elimination, and alveolar ventilation was that other, this is really a critical equation conceptually for us to understand. The higher the VCO2 is, in other words, the more CO2 we're producing, the more alveolar ventilation we have to blow that load off, and those two, when they're balanced, give us a PCO2 that's within normal limits between 35 and 45 millimeters of mercury. If we look at the ratio between CO2 production and oxygen consumption, or at least from our exhaled gases in a steady state, we get something called the respiratory exchange ratio. In a steady state, the respiratory exchange ratio reflected by these exhaled gases accurately reflects, I'm having trouble with my mouth this morning, it accurately reflects what's going on in the tissues, and that's typically called the respiratory quotient. Now, since the second module, we've been calculating the alveolar PO2 using the alveolar air equation. We've been dividing PCO2 by 0.8, and I told you I'd tell you why later on. Now is the time. It's actually a correction factor because we have a difference between CO2 production and oxygen consumption in a steady state. So this 0.8 is where that consistent factor that we've talked about in the alveolar air equation comes from. As cardiac output increases with exercise, we also increase minute ventilation with exercise. And just as with cardiac output, early in exercise, we have a lot of cardiac output increase because of an increase in stroke volume. With ventilation early in exercise, we have an increase in tidal volume. That also peaks at about 50 to 60% of vital capacity part of the way through our exercise. So the way we do that is we have to breathe deeper, and we go back to that table of lung volumes and capacities that you were supposed to learn. That means we have to breathe in deeper to our inspiratory reserve volume, and it's a reserve because it's there when we need it, like in exercise. And we actively exhale. We contract those abdominal muscles and internal intercostals to actively blow air out and blow down into our ERV. So if you think about that, what would happen with functional residual capacity with exercise with this active exhalation? See if you can come up with that answer. So we recruit or activate these muscle groups to do more ventilatory work. Because we're also increasing respiratory rate along with increased tidal volume, we have to have higher inspiratory and expiratory flow rates. We've got to get that deep breath in quick. We've got to get that gas out fast if we're going to breathe at a rapid respiratory rate. And realize that with high work rates, we might have respiratory rates that are in the neighborhood of 60 breaths per minute, which means you've got a second to get gas in and out. Large volumes in and out requires high flow rates. So we go from our normal breathing to this kind of breathing. So once again, think about what has to happen in a normal person to FRC with exercise when we actively expire. Now, when we actively expire and we blow down into that ERV, we're also going to be pushing the diaphragm up higher. We're going to have to make the chest smaller in that vertical dimension, at least. And that exhalation, making the diaphragm go higher, pre-stretches it. And like we've talked about with the Frank-Starling curve, if you pre-stretch a muscle, it'll increase its ability to generate force. And that's really important when you have to breathe in deeper and get that deeper breath in faster. Since we're actively exhaling, when we blow, if we blow actively, we're going to be squeezing gas out of airways, so we actually have higher resistance to exhalation. But when we breathe in and deeper, breathe in deeper into the inspiratory reserve volume, that's going to open the airways as well as stretching alveoli. So that's going to help us generate a higher inspiratory flow rate. So we've got different dynamics acting on the airways during forced exhalation versus forced inspiration. And as you can imagine, remember we're talking about normal individuals, forced expiration is going to do different things to a person with emphysema, loss of elastic recoil, and we go back to that equal pressure point theory of airway collapse in emphysema. So again, limitations of exercise in disease states. The physiology is important. We increase respiratory rate. In doing so, inspiratory time and expiratory time both get shorter. So if inspiratory time and expiratory time shorten with a bigger volume, think about what flow is. Flow is change in volume over time. Flow rates have to go up dramatically. So in a pulmonary function lab, we'll measure flow versus volume, not just flow, or not just volume versus time, which we've looked at a little bit. We're also going to be looking at flow versus volume. And this graph is laid out so that expiratory flow is on the upward part above zero of the y-axis. Inspiratory flow is on the downward or below zero portion of the y-axis, and volume is on the x-axis, volume in liters. So in the middle of this, we've got a tidal volume curve. So somebody is breathing a normal tidal volume at rest, 500 or 600 milliliters, and then as they exercise, their tidal volume gets bigger and their flow rates get higher. So we're changing tidal volume and flow rate with exercise. Now, we said that we're not going to breathe at vital capacity. Our volume, our tidal volume, will get bigger, maybe to about 50% of our vital capacity. And in this case, vital capacity is from, let's say here, 0, 1, 1.3 liters up to a little over 6. So vital capacity in this person looks like it's in the neighborhood of 5 liters, pretty close to what we had on our 6-liter model. But with exercise, tidal volume looks like it's between 2.3 and 4.7 liters. So if I can do that math in my head, I didn't bring my calculator, it looks like that tidal volume has gone from 500 or 600 milliliters up to over or almost 2 liters. So we've got a bigger volume with higher expiratory flow rates and higher inspiratory flow rates. But notice that we haven't reached our volume capacity, and we won't, nor have we reached our flow capacity. When I do a forced vital capacity maneuver, I have my person breathe all the way in as deep as they can, and then blow that gas out. We have peak flow early in expiration. Flow decreases as they continue to squeeze that gas out, and then they breathe in fast and deep and close the loop as they go back to total lung capacity. Notice with this young adult of age 30, with a max VO2 of 42 milliliters per kilo per minute, which is, how many METs is that? What is that? In the neighborhood of, let's see, 42 divided by 3.5. That's probably in the neighborhood of, 17 METs. I'm trying to do a guesstimate in my head, 16 METs. This guy never comes close to reaching his peak flow rate that we generate during a forced expiratory maneuver. In other words, he's got a flow rate reserve. He's got a lung volume reserve. And he's got an inspiratory flow rate reserve. So the point that I'm trying to get across here is, from a mechanical standpoint and from a volume and flow standpoint, the lung in this normal, young, healthy adult does not limit his ability to do exercise. Notice what happens with dead space to tidal volume ratio. And I want you to think about what we said was a normal range at rest. VD to VT ratio is only 21% in this guy during exercise. We talked about that in our pulmonary blood flow chapter, because if we start to perfuse our apical alveoli with an increased cardiac output, if we recruit those alveoli, we make them less like high VQ or dead space and more like the 1-to-1 ratio of ventilation and perfusion that we get with perfect matching. So from that standpoint, our VQ matching becomes better. It's improved with exercise in a normal person. Now, the other reason why VD to VT ratio goes down clearly is because this person's breathing with a dramatically larger tidal volume. This guy's arterial PO2 is 94 at max exercise. Part of the reason for that high PO2 could be that this test might have been done at sea level, but he's also hyperventilating. His PCO2 is down to 34, and we know that when CO2 goes down, PO2 goes up. Notice what happened to pH. pH at the end of this test is 7.3. At least I'm assuming it's the end of the test. How does that compare to the normal range that we have for resting pH? And we'll talk about why it's 7.3. So we said this maximum peak expiratory flow rate at rest, in other words in a pulmonary function lab setting, is greater than that PEFR, peak expiratory flow rate at maximum exercise. If I ask people in my pulmonary function lab to breathe as deep and fast as they can, I'm going to do something called a maximum voluntary ventilation test. In other words, breathe in, breathe out, breathe in, out, deep, out, in, out, for about 15 seconds. And I'm going to convert that volume to what they would breathe in a minute. I'm going to compare that to their minute ventilation and exercise, and their maximum voluntary ventilation at rest always exceeds what they do with exercise. Once again, the lung does not limit their ability to do exercise. It's got to be something other than the lung in a normal, healthy individual. Now, we said that the diaphragm, internal intercostals, external intercostals, abdominal muscles, they're all accessory muscles of ventilation. Now, even though they work very hard, they're working with someone with normal compliance and normal resistance to stretch the lung and generate these flow rates. Their oxygen cost of breathing, in other words, the oxygen consumed by the ventilatory muscles, is still only 10 or 15% of the max VO2 in somebody who's normal and relatively fit. But if somebody has got stiff lungs, low compliance, high elastance, or they've got airway obstruction with high airway resistance, limited flow rates, this is not going to be true for somebody with lung disease. Their muscles of ventilation are going to consume a much larger percentage of the maximum oxygen consumption that they can generate. And the reason why this is important is if the ventilatory muscles are consuming a higher percentage of max VO2, that means the legs or whatever is doing the exercise is not going to have that oxygen available to them. So we're going to have another limitation to exercise capacity in somebody with lung disease. Now, we said that pulmonary blood volume increases with exercise because cardiac output is systemically is going to be essentially the same as pulmonary blood flow. And we said that we've got a distensible low pressure system, and it has to be a low pressure system because the right ventricle is the weaker ventricle that has to generate that cardiac output. And we have to expand the pulmonary capillary bed so that those red cells don't have to rush through that alveolar capillary interface. We want to have adequate time of capillary transit time to be adequate to oxygenate the blood. So there are lots of things that happen with exercise in a normal individual with exercise. We recruit those apical vessels, which at rest in an upright person are underperfused. We will perfuse them with exercise. This limits or reduces the physiological dead space. And that coupled with a larger tidal volume decreases VD to VT ratio. Since this is decreasing, we can efficiently get rid of that higher CO2 load that we generate with our active tissues when we exercise. So everything is tuned for us to be able to do this very high level of metabolic rate. We talked about the Fick equation and all of the things that help us diffuse oxygen. If we increase perfusion of alveolar capillaries, we're going to increase surface area. We're going to increase that factor for diffusing oxygen, specifically also when we maintain an adequate transit time. Now, I said that if we're studying normal people, we're probably not going to order a blood gas. We're not going to put an arterial catheter in these people. So if we want to get a handle on CO2, we've got to look at exhaled gases. And we talked before about capnometry, that we can measure exhaled CO2. And if we measure the partial pressure of end tidal CO2 In a normal person, because we've got such a low VD to VT ratio, we're perfusing these capillaries better than we do at rest, we're going to assume that we're also collecting alveolar gas from this forced exhalation, this active exhalation generated by the abdominal muscles. And since we've got such good matching of ventilation and perfusion and low VD to VT, we're also going to say that those values are also reflecting arterial CO2. And this really is very accurate. So when we want to look at dead space to tidal volume ratio, if we assume that arterial CO2 is equal to end tidal CO2, we directly plug end tidal CO2 in from expired capnometry. We're going to plug that in substitution for arterial CO2 in our Paco-Pico-Paco equation. If we know VD to VT ratio, and if we measure minute ventilation, which we will because we're measuring expired gas, we can also come up with a value for alveolar ventilation with exercise. So all of the stuff that we've talked about before with CO2 elimination, we can measure in an exercise testing situation if we're measuring expired gases. Now normally, we really don't have much change in arterial PO2. In fact, in a lot of us, when we hyperventilate, that's going to increase alveolar PO2. It's going to increase the driving pressure for oxygen to diffuse, and it also increases our potential arterial PO2. So if we look at alveolar air equation, which we can do when we make assumptions, we can come up with a value for arterial PO2 that's going to drive that oxygen across into the bloodstream. And if our alveolar PO2 is higher, arterial PO2 will be higher if we have no problem with shunting and low VQ. Now we know that we're going to have a higher amount of cardiac output. Some of that cardiac output is going to go through our physiologic shunt, but hopefully that will not be a major limitation to exercise in most individuals. Might be a limitation in an elite athlete. Since we're increasing the CO2 in the tissues, and remember we had a drop in pH in that exercise test, and tissues are going to be warmer, blood temperature is going to increase, we're going to shift the oxyhemoglobin dissociation curve. So I want you to think back to that chapter. Which direction is that curve going to be shifted with exercise? High intensity exercise. If you shift the curve, we said that that's reflecting a change in affinity of hemoglobin for oxygen. And in an exercise setting, we want oxygen to be released from hemoglobin and go to the tissues. That also is connected to which direction our oxyhemoglobin curve shifts. So, if we do a graded exercise test with somebody who's on a treadmill, or in this case on a bicycle ergometer, and the reason why I know that is because the work rate on the bottom is being expressed in watts. That's typically the set of units that we express work on a bicycle ergometer. We've got somebody who starts off at rest and then gradually increases incrementally their work rate. So it's a progressive exercise test if you think about that terminology. And there are a lot of measurements that are made. We're going to be measuring exhaled minute ventilation in liters per minute at body temperature and pressure saturated, BTPS. So in other words, what would that volume be if it was in the body? So we do some corrections. Notice that this thing is scaled. This graph is scaled in minute ventilation from 0 to 120 liters per minute. 120 liters a minute is about 20 times our normal resting minute ventilation, isn't it? We look at VCO2, the volume of CO2 that's being produced, or at least that's being exhaled and measured. Those are in liters per minute, and that's at STPD, which the respiratory therapy students will remember is standard temperature and pressure dry. So we're going to be expressing VO2 on this axis with a scale of 0 to 5 on the right, and VCO2 on a scale of 0 to 5 liters per minute, both at STPD. We're going to be taking minute ventilation and dividing it by VCO2 and by VO2 and graphing those out, and those are called the ventilatory equivalents. We have a ventilatory equivalent for CO2 and a ventilatory equivalent for oxygen. From capnometry, we said we're going to be measuring expired CO2, and we're going to look at the shape of that graph. Then down below are all of our blood gas values that we could measure. Principal among them are lactate, and we said that if the tissues are exercising at a higher rate than oxygen is delivered to them, those tissues will become anaerobic. So we're looking for an increase in lactate production with high levels of exercise. As lactic acid is generated faster than it can be broken down, we're going to accumulate lactic acid, or lactate, the anion of lactic acid. That's going to play Pac-Man with bicarb. So we're going to decrease bicarbonate at high levels of exercise, and when bicarbonate goes down, pH goes down. Remember the exercise test we looked at, the individual had an ending pH of 7.3. So let's try and put this all together. As we start to exercise, we said we're going to have a linear increase in VO2 and we're going to have an increase in minute ventilation. So we started off with a minute ventilation of 5 or 6 liters a minute at rest, and then as we begin to exercise, minute ventilation goes up very linearly. VO2 with higher exercise goes up linearly, but it goes up linearly through the entire exercise test. Notice that these vertical dashed lines are separating the exercise test into a couple of different periods, if you will, or levels. The first level is called isocapnic buffering. Iso means same, capnic refers to CO2. So through this section of the exercise test, there's essentially no change in the partial pressure of arterial or end tidal CO2. During respiratory compensation, the VO2 continues to increase linearly. This is the finding that we talked about before. The harder we work, the more oxygen we consume. But notice that the CO2 curve, the VCO2 curve, and the minute ventilation curve do not continue to be linear. There's a break in the slope of those curves. So we get to a portion during respiratory compensation where there's a dramatic increase in minute ventilation. And if you think back to our acid-base interpretation chapter, we said that respiratory alkalosis compensates for metabolic acidosis. So during this respiratory compensation curve, when we have a dramatic increase in lactate accumulation, that lactic acidosis has to be compensated by a respiratory alkalosis. That's accomplished by an increase in minute ventilation, in this case a very dramatic increase in minute ventilation to nearly 120 liters a minute, and that's blowing off a dramatic load of CO2. So the volume of CO2 that's being exhaled also dramatically increases during this period. So we said that this is happening because lactic acidosis is occurring. Lactate is being produced faster than it can be metabolized, so it increases its concentration in the blood. That's also an increase associated with this increase in minute ventilation that we measure. Like I said, we really don't need to measure blood gases to find out when we've reached this anaerobic threshold, because we can do it through measurements of minute ventilation. Now up above we're looking at the ventilatory equivalent for oxygen, and we see that that also increases steeply when we reach the anaerobic threshold. In other words, we're increasing minute ventilation dramatically more than oxygen is consumed during this period of exercise. I'll say that one more time. Minute ventilation increases dramatically more than oxygen is consumed. in this period. So we get a very steep change in the slope of the ventilatory equivalent for oxygen. That's different than the slope of the ventilatory equivalent for CO2. And the reason for that is because we're buffering the increase in lactic acid, and as we do that, we're decreasing bicarbonate, which we said bicarb is the storage form of CO2. That CO2 is being mobilized from bicarbonate back into carbonic acid, which is a volatile acid, which is being blown off. So during this period, we're not only blowing off the CO2 that's currently being produced with exercise, we're also blowing off the CO2 that had been stored as bicarbonate. Since that's happening, there's only a modest increase in the ventilatory equivalent for CO2 because we've got a much greater increase in VCO2 in this portion of exercise than we have increase in VO2, because we're liberating stored CO2 from the form of bicarbonate as well as the CO2 that's currently being produced. So these are the reasons why we don't have to draw arterial blood gases to tell us when lactate goes up, because the measurements that we make from ventilation are directly linked to what's going on in arterial blood gases. So we said pH drops dramatically at high levels despite an increase in CO2 elimination. In fact, if we go back and look at end-tidal CO2, we can see that it does drop during this period of compensation for lactic acidosis. So pH drops because we're generating lactic acid faster than it can be metabolized. And it actually is metabolized by the liver and by the heart. And we said we may actually shift blood flow away from the gut at high levels of exercise to try to get more blood to go to the exercising tissue. As we end our exercise and we do our warm down, we're going to shift some blood flow back to the liver. That blood is going to be high in lactic acid, and it's going to metabolize. The liver will metabolize that lactic acid. So we go back to the concept that lactic acid is produced, and it's going to generate a proton and a lactate anion. We're going to have bicarbonate carbonic acid system as one of the major buffer systems that's functioning for acid-base balance. And when that CO2, when those hydrogen ions are produced, they're going to be bonding with bicarbonate, taking the stored form of CO2, bicarbonate, shifting it back to carbonic acid. Carbonic acid is a volatile acid that is going to form CO2 in water, and it's that CO2 that we can ventilate off if we can increase our alveolar ventilation adequately. So we blow off enough CO2 that our PCO2 actually can go down. So we're ventilating off volatile acid with exercise. Since we're taking that stored CO2 as well as actively produced CO2, liberating both of them or blowing them off at the same time, the volume of CO2 that we exhaled is dramatically increased when we get past the anaerobic threshold. So the slope of that VCO2 curve goes up dramatically, even though the VO2 curve only increases in a linear fashion. Since VCO2 goes up dramatically relative to VO2, we're going to have an increase to greater than 1 in the respiratory exchange ratio. If it's greater than 1, VCO2 has to be greater than VO2. And in fact, that's what we see when we're past the anaerobic threshold. So when we look at the ventilatory equivalent for oxygen, since minute ventilation goes up dramatically to compensate for this lactic acidosis, VO2 only increases linearly with work. The value of that ratio, the value of the ventilatory equivalent for oxygen, becomes greater than 30. In other words, minute ventilation is 30 times greater than oxygen consumption when we're past the anaerobic threshold because of compensation for this metabolic acidosis. So that's another way we identify the anaerobic threshold. So we go back to what compensates for metabolic acidosis: an increase in alveolar ventilation and respiratory alkalosis. That's what we see. We see a drop in CO2 during that, a drop in end-tidal CO2 during that compensatory period as compared to end-tidal CO2 being relatively stable. Now notice when we've got this ventilatory equivalent for CO2 in the isocapnic buffering period, it's a really very flat line through here. Notice though that there's actually a relative increase in end-tidal CO2. And I want to go back to the concept that as we exercise, if we increase perfusion of apical alveoli, we have a drop in dead space and a reduction in high VQ alveoli. We more efficiently get rid of CO2, and alveolar gas and tidal gas better reflects what's going on in arterial blood. So the difference between end-tidal and arterial here in a normal person is negligible. At rest, our end-tidal CO2 is maybe 5 millimeters less than arterial because we've got some high VQ ratio alveoli in the apices. Ventilatory equivalent for oxygen, again, goes up very linear, the VO2 goes up very linearly. The minute ventilation goes up dramatically in the compensatory portion of this curve. So once again, we get that dramatic increase in VE over VO2, much greater than the change in the slope of the ventilatory equivalent for CO2. All right, so we go back to what happens when we change from resting oxygenation to exercise. We have a pVO2 in resting mixed venous blood of about 40, a saturation of about 75%. If we have good VQ matching, we have equilibration of capillary blood and alveolar blood. Therefore, arterial blood has a PO2 that's very close to what's in these alveoli. We have a little bit of anatomic shunting going on. That's the reason for the difference between alveolar PO2 and arterial, but it's only a very small difference. A difference for oxygen is only 5 millimeters of mercury in a normal person at rest because we only have a little bit of low VQ and a little bit of anatomic shunt. With exercise, we're going to pump more pulmonary capillary blood flow through the lung. And despite the fact that we're consuming a large amount of oxygen, arterial PO2 really is pretty much unchanged. Partly, like we said, because hyperventilation increases alveolar PO2. We have a higher gradient for diffusion. And if we have a higher alveolar PO2, we have a potentially higher arterial PO2. We've got maintenance of capillary transit time because we've increased the pulmonary capillary blood flow bed by recruitment of those alveolar capillaries. Therefore, the blood doesn't have to rush through and we have an adequate capillary transit time. But if you have an elite athlete, like an Olympic sprinter, for instance, somebody who works at a very high load, they may actually have a reduction in arterial PO2 for a couple of different reasons. If they have incredibly increased cardiac outputs because they've trained their heart, they've got a huge stroke volume, they can pump tremendous cardiac outputs. Even when their pulmonary capillary bed is fully utilized, they may have a decrease in red cell transit time or capillary transit time. So they may not be able to fully saturate their blood with oxygen. And remember, they're extracting a great deal of oxygen from their blood. So their mixed venous oxygen is very desaturated. So that desaturated blood, a portion of which goes through our anatomic shunt, is going to reduce the arterial oxygen content. The other thing is, with this incredible cardiac output being pumped through their pulmonary capillary bed, remember we talked about the fact that hydrostatic pressure can go up. If pulmonary capillary pressure increases with this high cardiac output, they may actually form some pulmonary edema. And Jerry Dempsey, whose lab I used to work in Wisconsin, actually identified this in thoroughbred racehorses in part of his research, and then extrapolated this to what happens in elite athletes. So if we have somebody who's an elite athlete who hyperventilates, they get an increase in their alveolar PO2s, but they have a real desaturated mixed venous blood. They have a PVO2 that's maybe 26 and a saturation of 50%. So when that blood goes through the anatomic shunt, and if they have some thickening of their alveolar capillary membrane from some mild pulmonary edema, they may actually become hypoxic with exercise because they've pushed themselves past the limits of a normal person. This is an elite athlete. Therefore, their AA difference for oxygen is greater than 5. It's 45, and this AA difference is one of our indices of oxygenation that tells us if people have low VQ or shunting. Now, if you take me, well, 25 years ago, let's say, and got me on an aerobic training program, even though genetically I think I have the stroke volume of a gerbil, I would probably be able to increase my stroke volume through training. If I have a greater stroke volume, that means I can generate a cardiac output with a lower heart rate and bigger stroke volume. And I can exercise more easily with a lower heart rate at a submaximal workload. But if I'm doing a VO2 max test and you push me to my maximum heart rate of 220 minus my age, if I'm doing that maximum heart rate with a greater stroke volume, I'm going to generate a greater cardiac output. And if that greater cardiac output is delivered to my exercising muscle, I'll do more of that exercise aerobically instead of anaerobically. I'm not only training my heart when I do aerobic training, I'm training my tissues. So if I ride an exercise bike, my quads are going to increase the aerobic capacity, the enzymes that are aerobically able to extract and utilize oxygen in my tissues at my mitochondrial level. I'm also going to increase my capillary density. I'm going to have more capillaries there, so there's a shorter distance between my capillaries and my exercising muscle. So that also helps me get oxygen from my blood into those capillaries, or from those capillaries into those exercising muscles, and I'm going to have an increased density of mitochondria. So their mitochondrial aerobic enzymes are more fully developed. They have greater capacity, and I've got more mitochondria per unit of muscle mass, so I'm able to do more aerobic work. From a pulmonary standpoint, the question is, what do you think really happens to lung function with training? Well, since the lung is not a muscle, and we said lung function does not really limit exercise in normal people, there's really no significant change in any measurable characteristic of lung function. In other words, vital capacity doesn't change with training. Flow rates don't change with training. Our ability to diffuse oxygen in the lungs specifically, other than due to an increased cardiac output, the lung specifically for diffusion doesn't change with training. So when we look at responses to exercise, our minute ventilation, our maximum minute ventilation, our MVV doesn't change. And remember, we don't even get close to utilizing our MVV at maximum exercise in terms of our minute ventilation. We can estimate what maximum voluntary ventilation is from a pulmonary function measurement. My vital capacity is around 5 liters, and my MVV is 35 to 40 times that value. So 40 times my 5 liter FEV1, I should be able to ventilate 200 liters a minute at rest. But I may only get to 120 liters per minute, as we have on this scale, approximately 120 liters a minute of minute ventilation, when I say, hey, I quit, I give up, I can't do any more exercise. So I have a significant ventilatory reserve that I don't even tap into. The normal lung does not limit exercise capacity. I can ventilate like crazy. I can blow off CO2 like crazy. It does not limit my ability to do exercise. Lactic acid is probably the limiting factor, and lactic acid is probably produced because we have delivery that does not meet our aerobic demand. And oxygen delivery is primarily, in somebody who has normal arterial PO2 and saturation, is primarily limited by cardiac output and delivery of that cardiac output to exercising tissues. So lactic acidosis, the pain that we get in muscles when we exercise, a lot of that is due to lactate. And that makes our pH and our bicarbonate drop. With exercise, we have a metabolic acidosis that's partially compensated by respiratory alkalosis. Now, we're going to take emphysema as the primary poster child for limitation of exercise. So we go back to the fact that in emphysema, they have destruction of their alveolar septae. We take out those walls, and those type 1 cells in the walls generate elastic recoil. When we destroy those walls, we destroy elastic recoil. So we have lungs that inflate but don't want to deflate. Also in those walls are the pulmonary capillaries. So when we destroy pulmonary capillaries, we have areas that are poorly ventilated but not perfused, or are very poorly perfused. So we have an increase in high VQ and in dead space. That makes it more difficult for us to eliminate CO2. Since we've destroyed surface area, we have limitations in our ability to diffuse oxygen. And we go back to the fact that with loss of elastic recoil, we have dynamic airway collapse, goes back to the equal pressure point theory. We're going to air trap gas in those alveoli that don't have time to empty. And when we over distend those alveoli, that also is going to cause more high VQ and dead space. We're going to cut off the capillaries to ventilated alveoli. So we even from that standpoint are going to worsen dead space and impede CO2 elimination. If they can't increase flow because of airway collapse, the harder they work, the more they forced exhale, the more they're going to air trap, and we get a vicious cycle. Since they air trap, FRC gets bigger. The amount of gas they have in their left in their lung at the end of expiration increases, and if FRC gets bigger, inspiratory capacity gets smaller. So when these people need to take a deeper breath, they can't. And their ability to take that deep breath gets worse and worse and worse as they exercise and air trap. Their diaphragm gets flatter when their FRC gets bigger, and we know that a flat diaphragm is not pre-stretched. That also is going to be a limiting factor in their ability to ventilate, and we call this a mechanical disadvantage. We said that they're going to have problems with loss of surface area. They're going to have reductions in capillary transit time relative to a normal person. They're trying to pump more cardiac output through their lung, but they don't have ability to expand their capillary bed because it's been destroyed. This limits or reduces their capillary transit time as their right heart is trying to pump blood through a bed with high pulmonary vascular resistance. So we also, since that right heart can't pump more blood flow through the lung, we have a limitation in cardiac output. And it's cardiac output that's going to deliver oxygen to tissues, right? We have an increase in CO2 production, but we have a limitation of alveolar ventilation, so we can't blow off that CO2 load. If these people can't increase their alveolar ventilation, they can't hyperventilate. They can't reduce their PCO2, and we said that hyperventilation is the way they would be compensating for lactic acidosis and also trying to increase alveolar PO2 to maintain that oxygen delivery. So all of these things are adding up to be issues that limit their exercise capacity. Cardiac output limitation is going to prevent us from dramatically increasing delivery of oxygen to these tissues, which, by the way, in an untrained person, sedentary people with emphysema, their muscles are really out of shape. They're detrained. And essentially, the thing that limits their ability to exercise is their dyspnea. DOE is the abbreviation for dyspnea on exertion. These people quit exercising because they just can't breathe. So, in a nutshell, that's exercise physiology. And I think this ties everything together from a pulmonary standpoint and a cardiac standpoint, both in normal individuals, in responses to training, and in limitation of exercise. And it helps you to understand, at least from an emphysema patient standpoint, why these people just can't get up and go for a run. And hopefully you feel the same way, that this exercise ties everything together.